Thank you, Dr. Minter. That was very insightful, especially seeing the videos that you were showing in the beginning. I think it was the first case looking through and separating both the femoral component and also the spacer, being able to separate that with the VersaDriver blades. I see one question coming in regarding, do you see, Dr. Minter, any use in removing shoulder stems? I don't know if you have experience with that.
Wow, man, it's been many a moon since I've used it to work on a shoulder. But I think, you absolutely could. There's a smaller length blade that you could easily work into that interface on these shoulders. And of course, actually, depending on kind of your technique, it could be good for cement extraction as well. Glenoid side, it's all about exposure, right? So if you can get on that edge between, bone and implant, you're liable to be able to make a difference there as well.
Another question about saw blades. From your perspective, how does pneumatic osteotome compare in terms of precision, efficiency, and safety compared to using saw blades that are commonly used?
Woo, boy, that's a loaded question. There's a lot of stuff in there. Okay, so, well, definitely I'd say from a safety standpoint, I mean, if you're using a manual osteotome, there's that possibility that something could go south. And I just think to one of my old colleagues, actually now deceased, bless her heart, but she was in a residency training program and had an osteotome basically driven through her hand. So not such a good thing. So yeah, safety wise, there's that issue. And of course, those incidences are rare. I think that, for a manual osteotome, which a lot of times that's all a hospital is going to give you is just that box of osteotomes. The problem is that if you used it like the week before and maybe they didn't sharpen them, then all of a sudden you've got osteotomes that aren't sharp. The other thing too is they're double beveled versus the VersaDriver that has that single bevel. So as a result, you can put that flat side right underneath an implant or right next to it and drive it, which that's highly efficient and an osteotome, depending, I mean, it actually takes up a lot of space. These blades are pretty thin, but they're really hard, so very hardened metal. I'm not sure. Did I answer all of that? There's a lot of stuff in that question.
No, definitely. I think again, just to your point about saw blades, just even though they're commonly used, just how that compares to using the VersaDriver blades.
Yeah, I've just not been a fan. I think you can generate metal debris. I think that blades aren't beveled, right? So depending on the angle that you hold it, what's going to happen is you're going to potentially drive that saw blade, right into a condyle or maybe out through maybe through a calcar or underneath the trochanter. It just, but especially around the femur, I think you can end up actually probably taking more bone than would be necessary. So yeah, I like the way it preserves bone, and then you get to make your decisions based on really what you've got, not essentially by something you've created more or less.
Got it. And do you personally have experience just kind of using VersaDriver for cement removal from femoral canal after removing stem?
Yeah. I mean, for example, the case that we just showed, the cone, it's probably a smattering of cement in and around there. But yeah, I mean, if you have cemented a stem, it's got that nice curved blade. The narrower blade's really good, and you can just basically go down through there and split that away from the endosteal canal. And yeah, it's pretty efficient. Get a pituitary rongeur and you're off to the races.
Right. And another question about the number of blades. How many blades do you typically use in the course of the procedure?
Yeah, I will say it depends. If you have a ridiculously osteoporotic, let's say female patient, cemented, maybe the implant's been in there for a while, you can get right underneath that cement interface along that bone. And honestly, I will say one blade could probably do it. I tend to use two blades because you want to use sort of maximal sharp. So I'll do one of the femur, one of the tibia. I think as far as the hip goes proximally, to get some of these cementless implants out, using some big K wires in and around them, and then try to connect the dots. I think that is a great way to go as well on the hip.
Perfect. Thank you. In terms of safety, I know you mentioned earlier having trouble, not safety, sorry, reliability, trouble with blown hoses or motor failure. Have you noticed that with the VersaDriver compared to what you had in past?
Oh no, not it's not even a problem. You don't even think about it now. But that was honestly, so I had the same personnel in my OR consistently, and it used to be almost like a joke. Is it going to work this time with the former implant? With VersaDriver, honestly, it's been great. It's been, reliable. And so we don't get that little anxiety feeling before you start using it.
Got it. I think you mentioned safety before, but how does the pneumatic osteotomy compare in terms of safety for both patient and the surgical team compared to saw blades or osteotomes? Any thoughts there? Any experiences you might have had?
Yeah, I think getting back to that, probably the fact that it's only got a 3 mm oscillation. I mean, it's not like it's extending, 3 to 4 inches, and you're holding. I mean, it's because of that it's actually ridiculously controlled because of that. I mean, you do want to put two hands on it. It's not like a one-handed, pistol grip. You want to hold it with both hands for just for efficiency, more or less. Yeah.
Yep. Got it. Thank you. I think Amy has a question. Amy, if you could unmute yourself and ask your question.
Oh yes. Hi Doc. I have just got an add-on for an S-ROM revision coming up. I think it's, let me look, is it a knee or it's a hip? So sorry, I don't know. What are the best blades I should have in the case for that, for the VersaDriver?
Yeah, well, I tell you what, S-ROMs, they're ridiculous. They're ridiculous implants. I still think that any surgeon should probably go ahead and put a timer on himself if he's struggling with trying to get any cementless implant out of a hip, or cemented if it's for that matter. But for me, for something like that, what I'm going to do is I'm going to basically try to clear out that shoulder before I really get to work on anything. I'm going to use some big K wires or reasonably sized K wires to go around the entire sleeve. And, then I'm probably going to do more of the curved tip blade, VersaDriver blade, for me to connect the dots. You don't want to go with a broader blade because, sometimes, I mean, if the bone envelope's, well, I mean, if it's a small female, you're going to end up cracking it. So in an effort to avoid that, that's probably the best solution. The trouble is those stems are smooth and highly polished, but man, it seems like the bone loves those things down there. So, but trying to free up that cone will be a key, and that's what I would suggest.
Great, thank you so much.
Yeah,
great.
Welcome.
Do you see like them working together? If you had an ultrasonic cement remover and VersaDriver blades, do you see them working together?
Oh yeah, no question. I mean, for example, if you've got an implant out and you got a lot of cement in a canal, you could easily use the VersaDriver to basically break up, the exposed portion of the cement that you can see and see well. You hopefully have a light on your hood, stuff like that, so you can really see down the canal. But that deep stuff, I mean, if it was well done and it was high and it was pressurized and they had a cement restrictor, that's really going to be a tough sled. So it'd be sledding. So it'd be nice to to have an ultrasonic device that works and works well.
Got it. Another question just came in, I think a few minutes ago. Do you have a certain sequence or order of attack when you use the using VersaDriver? on femoral removal or any technique tricks on positioning and manipulating. Sorry, I have to press more here, bear with me. Blade, do you prefer shorter or longer flat versus round blades?
Yeah, I would say shorter is better around the knee. I think it gives you a little bit better control. I think that what I would suggest for the surgeon is that they honestly probably should see whether the basically the straight blade or that curved blade, see how it works in their hands. You know, for me, I tend to go with one that's just, you know, it's got the straight tip. That seems to be my workhorse, where I'll use a couple of those. You know, I've used the curve in the past, and I don't know, I've just kind of evolved to using a couple of those straight blades. And the one that basically has, you know, that's you know curved like this, you know, almost like a scoop. That really works nicely on that cement that's down the canal. And it could also work around cones, but I'm not really, guess I really haven't really used it for that, but I probably should.
Got it. Thank you. Thank you for that. Another question, technique question by Sean. Would you recommend holding the trigger throughout the in and out of the implant interfaces? Thinking similar to rebeam canals, not stopping to limit the possibility of getting the blade stuck.
Well, this is what you want to do. You want to work all the edges. You want to really free up as much of the edge as you can. Then you can start to plunge deeper. A rookie mistake is to drive it and to keep driving, and you have to stop it. You can't keep doing that because it's almost like a car that gets stuck in drive, and you can't get it in reverse if you've got your foot on the pedal. So the idea is to take your finger off the trigger, you know, work it back. And if it does get stuck, then just, you know, just use that little slap hammer extractor. But I think you'll find that if you use it around the periphery, and then as you know that you're progressing into the, you know, into that central part on the tibial side, for example, or the femur. Yeah, and I think, you know, some of the femoral components, you know, have that cut out centrally for telefemoral, and what you may want to do is just take it up to that edge. It may be hard to kind of get around that, but it'd be hard to get around with any implant system. And usually the bone's pretty soft there anyway, so it's going to come away fairly easily once you get those edges. But I'm going to do the femur first, and I'm going to work on the tibia after that. But the key thing is it's all about exposure. Those of you that do a lot of this, you're going to make a bigger incision. You're going to cut out all the scar. You're going to free up the gutters. I tend to get rid of the scar on that retro extension mechanism, especially because that's how you gain mobility, and that's how you get exposure. And I also use all those old Intermedic Sulzer retractors that I used when I was a fellow, because they're real small and they don't take up a lot of space, or you're not putting big Homans in there. So just a thought as well.
Dr. Minter, I just have a quick question for you. Do you feel that when you're using like manual osteotomes versus VersaDriver, that the single bevel of VersaDriver is as sharp? And also, how do you feel the control is with the single bevel versus the double bevel?
You know, the thing is, I can tell you that from my early experience with the Exactech product, this single bevel is clearly it is like the way to go. Double bevel, it's just, you know, it'll take off. It's actually some characteristics like a saw. It'll kind of follow its own path if you angle it wrong. And those tend to be just a little bit thicker blades too. And as a result, they take up more space. You know, I mean, conceivably could crush a little bit more bone, things like that. I just find the single is perfect, and has been. Yeah.
Great. Now, when you're using the single bevel, do you feel that it is better for, like, I guess if you're taking out a cone or a stem, do you feel that the bevel facing the implant side or the bevel facing the better way to describe it?
You want the essentially you want it to where the flat side of that blade is hugging the metal. And as a result,
Okay.
that bevel, what it does, it'll push into the, it'll push that bone away as a result of that. That's been my
Awesome.
experience.
Thank you.
Yeah, you're welcome.
Thanks, Dr. Minter, and thanks everyone again for joining. This is again very insightful for us to walk through Dr. Minter's own experiences and cases. So thank you again for this.